Okay, so for this video, we're going to go over blood transfusions. So this is going to be initiating and monitoring blood therapy. Critical elements for this are on Blackboard, so that you'll be able to follow those as you go through in preparation for testing. Some reasons that we are going to need to do a transfusion. So causes could be anemia, maybe sickle cell anemia, generalized anemia, postpartum hemorrhages after a mom delivers a baby, acute bleeds, could be trauma related. It could be like a GI bleed with the gastrointestinal bleed, whether it's a lower or it's an upper, oncology and cancer patients, and then other chronic disease processes. And the reason we're going to give them blood is we need to replace the blood volume that they've lost, whether it's something that's been happening slowly over time or it's an acute issue. So say you are in a more emergent situation, O negative is universal. So anybody can receive O negative blood. However, if a patient is O negative, they can only receive O negative. For the actual procedure of going through blood transfusion, there are some things we need to have in place. Of course, we have to have the physician's order that tells us exactly what we're going to be giving. Maybe we're giving them packed red blood cells or platelets, plasma, albumin. These are more colloids, so they're a thicker type of liquid, so to speak, as opposed to your crystalloids, which are your IV fluids. We have to have consent from the patient. If it's an emergency situation, whatever your facility's policy is, maybe it's two healthcare physicians come to the conclusion that the blood needs to be given, and then they'll get some O negative blood for the patient if it's maybe a trauma situation. We need to review the patient's chart to see if they've had any transfusions in the past, and if they have they had any reaction. Of course, if the patient's able to communicate with us, we would ask them that. And if they have had a reaction, what were some signs and symptoms that they've had? If they've had the reaction, oftentimes we will get an order for oral Tylenol and either oral or IV Benadryl to pre-treat them, usually about 30 minutes before we get ready to initiate the blood. Lab work that you need to check is the type and cross, and that is looking at the patient's blood type and whether or not they're Rh negative or positive. And it also can look for any specific antibodies. Some people, if they have transfusions after transfusion, they develop antibodies. So if we're able to determine those, we can get them blood, hopefully, that doesn't cause any issues and increases risk of reaction due to that. The type and screen is good for 72 hours in most cases, and they are down to the minute on that. We also need a CBC, which is a complete blood count, specifically the hemoglobin and hematocrit levels. A lot of facilities in med-surg, if a patient is under 7 on their hemoglobin, then we are likely going to transfuse them with 1 unit of blood, maybe 2. It varies depending on the patient for whatever their diagnosis is, whatever their past medical history is, and also your facility's policy. And in that CBC, we also look at the platelet count, and we can see what our red blood cell count looks like. For coagulation studies, we're looking at the clotting of the blood. So we're looking at a PT, INR, and a PTT. So we would look at all of those prior to giving blood to our patient. We want to get a vital sign baseline. Again, checking to make sure that the patient's not febrile. If we have any abnormalities, obviously we're going to let the provider know. Temperature, like I said, we could give them Tylenol to pre-treat and then give them after. Then we have to check our IV patency. So I'm going to go ahead and check patency, and then what I'm going to do is I'm going to get some fluids running to kind of keep the vein open. So we call it KVO, stands for keep vein open, and we run the fluid at about 30 mLs per hour when we program it on the pump, okay? Just so you know, the tubing that comes in your totes does not fit in our Baxter pumps. So when you come in for practice and for testing, you will actually be doing it by gravity. So I'm gonna do it that way. All right, so I need my Y tubing, and we see in the corner that it says it is approximately the 10 drops per milliliter here. So there's two, this is why it's called a Y. We've got two tails here, okay? We've got two spikes, we've got two roller clamps, we've got our vented chamber here. This is gonna help with filtering. We have our main roller clamp down here, which is when we're doing by gravity, this is what we're gonna use to adjust how fast or how slow we're going. And then of course we have the end here. Since we are going to be using a simple connector, I'm gonna have to put an alligator clamp on the end of this. I have all my clamps closed right now. All right, and then the other thing I would need is my bag of saline. And just like you would do with any other medication, we check for expiration date, clarity, making sure that there's no rips or tears, that the integrity is good. Oftentimes we'll use like a 250 ml or a 500 ml bag on a regular med-surg floor instead of a full liter bag. There may or may not have the saline order in the MAR. In the past, when I've worked on the floors, it was not specifically in the order, since it's kind of more so for a flush, but you may have it depending on where you're working. I will also need a flush, and since it's a simple connector, I have a blunt tip cannula on the end of it. You'll need your alcohol swabs, and you'll need gloves. So I'm gonna go in and introduce myself and let Ms. Mary Jean Johnson know that I am going to get ready to do the blood transfusion for her. She came in with a lower GI bleed. We'll say her hemoglobin is at a 6.8 and she's usually around a 9. They do want us to do 1 unit of packed red blood cells for her. And I'm just gonna get her IV going so that I can go and get the blood. Can you tell me your name and your date of birth? And she tells me, are there any allergies? No, she doesn't have any allergies. Have you ever had a transfusion? And she says, no, she has not. So I can explain to her things that I've discussed earlier in this video regarding why we want to replace it. She's obviously lost blood. That can have issues with circulation. So we want to make sure that we get the blood replenished. Do you know what your blood type is? And a lot of patients might not know it. So we're going to have to look at her chart. Excuse me. And it says that she's B positive. All right. So I scrubbed for 15 seconds. I'm connecting. I'm going to aspirate for blood, and I get it. And then I'm going to slowly flush. And I'm just going to clamp it back up for right now. This is going to go into my sharps container. All right, Mary Jean. So what I'm going to do is I'm going to get a little bit of some IV fluids running for you. This is just going to help keep your IV line open and running while I go and get your blood. I did her vital signs. She is stable. She's not febrile. She didn't have any pain. She says, okay, that's fine. So I'm gonna use one of these spikes to spike my bag. And again, if you had something in the MAR, you would scan her and scan the bag into the MAR. I have everything clamped. I'm going to hang that. I'm gonna undo my roller clamp for that. And I am going to squeeze because I want to fill the filter up to the top of the filter. Sometimes you have to, you know, chop it a little bit to get it to fully cover. All right. And then I'm going to slowly cover all the way through to the end of my alligator clamp. And I have the trash can here that I can run it into. I'm gonna make sure I don't have any bubbles. Okay, I don't have any bubbles there. And I'm gonna back prime by opening this a little bit to allow the saline to prime in this second line. So you'll see that the fluid goes right in there. So we've got that primed. All right, now I'm ready to attach my alligator clamp to her. So it's again a 15-second scrub. And I said KVO before, which was keep vein open, which is 30 mLs per hour if we programmed it on the pump. And by gravity, it's like 5 drops per 1 minute. So super duper slow. Connect, and I'm unclamping it. And then I will set this by gravity. I would use my watch, and I'm gonna look here for my drops. And like I said, this is super duper slow. So it's literally gonna be like 5 drops in 1 minute. Okay, we'll say that we've got the 5 drops in a minute. And now I'm gonna go and get the blood. So, basic rule of thumb is that you have 30 minutes from the time that you get the blood from the blood bank to get it infusing into your patient. So that's why having the KVO is nice, because it's gonna make sure that that IV stays patent while you go and get your blood. If you don't check your IV for patency, you go and get your blood, you come back, the IV is blown or bad, then you're trying to find an IV in somebody who has low blood volume. They're probably hypotensive, so their veins are getting dehydrated. Finding a new IV is going to be a pain in the rear. So get this set up and going so that way it's ready to go when you get back. I'm going to go and get the blood, go through that whole process of dual signing everything with the blood bank. You could have a nursing assistant go and get it for you, as long as it's okay per your facility. And this is what your blood cell is going to look like. And this is simulated, but this is what the bag would look like. It'll have the collection date, the unit number, when it expires, the type of blood that it is. So this is, this example is A negative. It'll say volunteer donor on there. If it was their own blood, it would have their information. But we're going to use our lab made one here, which shows my requisition here for Mary Jean Johnson. Her patient identifier, the type of blood is B positive. For her type, the type that this is B positive. The unit number, when it was collected and when it is expired. And then there's usually somewhere that says how many mLs are in there, roughly. So I'm going to get my second nurse to come with me, my second RN, and we're going to go in the room together. We've already looked at labs and everything outside of the room, but now we're going to go into Ms. Johnson and we're going to do all of these identifiers. A lot of facilities now have the scanning process. So you would scan for the patient's name and date of birth, and then you would pull up your blood administration record and scan your bag of your blood, and it would populate your information. But you're still going to do a verbal confirmation. So with Nurse Amy, I'm going to read off of my requisition here, make sure that it matches my bag while also looking at my screen here. So it's kind of, we're going to do a double check here. I'm going to make sure that it says Mary Jean Johnson and her MRN number, which is 357159. We're going to make sure that those match. She is B positive. The type of the blood is B positive, and that's correlating in the computer. We have our unit number is 72RL217, and that matches 72RL217. It expires 3/2 of 2021, and it collected on January 1st, 2020. So, and we know that we have 325 mLs in here from a volunteer donor. So we've done those checks, we've scanned it in, everything is matching perfectly. We've looked at our bag to make sure that there's nothing contaminating it. No chunks or clumps of blood cells in there, nothing that's discolored. It should be a nice deep dark red. There shouldn't be any greenish color or anything that could be contaminated. Again, it's not expired. There's no leaking or anything. We've already compared everything. We did our hand hygiene and we have got the gloves on. And we've already prepared our line. So what I'm going to do now is stop my fluids, and I'm going to close my saline lock up here, or my roller clamp. So all of them are closed now. And what I'm going to do is I'm going to spike a second tubing with my blood and put it up here, and then I'm going to open my clamp. And again, saline is closed, because if I open the saline at the same time as the blood's going to back up into the saline, and then you've got ruined product. So I only have the blood one open, and I'm going to squeeze, make sure that my filter is completely covered. Like I said, sometimes you gotta really chop it. No more half full on this top, because that's where you're gonna look for your drops to make sure those are dropping. And then we would regulate our blood. So we're gonna do 2 mLs per minute for the first 15 minutes, which equates out to 120 mLs per hour if we were gonna put it on the pump. If we are doing it by gravity, which we are, we would be doing, and you'll do your dimensional analysis, but 20 drops per minute is what I calculated for how fast I'm going to run this over the first 15 minutes only. I'm going to stay with the patient for those 15 minutes, and I'm going to monitor their vital signs after 5 minutes, after 15 minutes total, after 30 minutes total, after 1 hour total, and then every hour. However, follow whatever your facility's policy is. The first 15 minutes are the most important. We can't leave the patient. We have to be with them at the bedside. The first 15 minutes are when your acute reactions are going to occur. So I'm going to regulate this. Now my timing for my 5 minutes cannot start until the patient is actually getting the blood into their arm. So All of this is saline right now, and I'm going to go through and I'm going to start to regulate my drops per minute. Just going to move this up here so I don't get the bed wet. Okay, so I'm going to let this, so I'm getting my drops regulated, and I need to be at 20 drops per minute. So start slow and then move up from there. So with 20 drops per minute, about every 3 seconds, I should have a drop. And I watch with my watch, and I'm getting 1 drop every 3 seconds for 20 drops per minute. And I see that the blood has traveled all the way down the tubing and is going into the patient. I start my timing, and in 5 minutes, I'm going to take a set of vital signs. Obviously watch for any alterations in breathing pattern. They complain of pain. Then I'll do another set at 15 minutes, at 30, at 1 hour, and then every hour, or whatever your facility's policy is. Bear in mind, if there's any change in condition with your patient, you're going to get a fresh slate of vitals right then and there. Okay, so what happens if they have a transfusion reaction? There are actually several different types of reactions that they could have. They could have a mild allergic reaction, severe allergic reaction, acute hemolytic reaction, bacterial contamination, and then there's also a very severe one, which is disseminated intravascular coagulopathy. So we're not in the lab, we're not going to ask you very specific things about the different types of blood type, but for lecture, you definitely want to brush up on those because you'll probably see them on exam questions. And I believe there is a spreadsheet that has information about the different types of reactions and what signs and symptoms you might see on Blackboard. And then of course you can refer to your textbook as well for all the information. What we're looking for are that if you see a reaction or your patient complains of pain, you see a variability in the vital signs, we're going to stop this infusion immediately. We're going to stay with our patient. We cannot leave our patient alone. We're going to get a fresh set of vital signs. We are looking for fever. They can have tachycardia, increase in respiration, complaints of shortness of breath, complaints of dyspnea, complaints of pain. Sometimes could be the chest or in the back, like the kidney area. Hives, rash, or flushing. And so what I'm doing now is I'm going to disconnect, because I stopped it. I'm going to flush and disconnect. If I don't already have a spare saline in a new primary line at the bedside, I am going to request somebody to bring it in for me. A 1 liter bag of saline and a primary tubing stat. I'm going to get that new line up and running as soon as it arrives, or if I have it at the bedside, I get it up and running. All of the blood tubing is going to go back to the blood bank. We're going to notify our provider and let them know that there is a suspected transfusion reaction, and they're going to put in orders for blood draws and urine usually. Will be urine specimens, and then also look at CBC again. We'll look at our coags, and maybe a D-dimer depending on what your facility calls for. So to see if we can figure out what kind of reaction they're having if it's not showing very specific signs. And then of course you're going to document everything in the chart. So that is the blood transfusion process. Again, refer to your textbook for those time frames, and also on how to calculate, if you were to be giving by gravity, how you would calculate that out for the remainder of the blood. Blood needs to be given within 4 hours. Usually in the order it'll specify, maybe they want it given over 2 hours or over 4 hours. A lot of times it's our judgment based on the patient's disease process, their age, how their veins look, their vasculature, and their risk for, having a reaction or becoming fluid overloaded. But that is it for blood transfusion.